Test, test. Can you hear me now? Good. Good morning. Look at the bright side, gang. After this, you have one more Monday when you have to get up this early. So I hope you had your coffee or chocolate or whatever you do to wake yourself up. So strap on your seatbelt and let's go ahead and get going. So I finished podcasting chapter 22. I will finish podcasting 23. Hopefully sometime, well, it'll be nice to get it done today, but I don't know if that's going to happen, but I'll try. And then we have Monday, and we have the final. So there we are. So we're getting towards the finish line. So I realized again that Zoom isn't ideal, but we'll do the best we can with it. Very good. Let's have a word of prayer and then we'll begin. Father in heaven, we thank you so much for this day. It's cold, but Lord, please let Spirit be the warmth inside of us. Give us a love for others. Lord, we pray for those who are sick. We pray for those with friends or family who are sick. We pray for the healthcare workers on the front lines, taking care of those who are sick. Lord, strengthen them. Be the great healer. And the rest of us, Lord, help us to exercise wisdom, to exercise hands, face, space, ventilate. Help now learn. In Jesus' name, amen. Very good. So today we're going to look at cardiovascular, lymphatic, and systemic types of diseases, looking mainly at those organisms that colonize the circulatory system. So the heart is a pump. The heart has 3 layers. So it has the myocardium. That's the epicardium, the outermost layer, then the inner myocardium, then the innermost layer is the endocardium. The endocardium is exposed to the blood, and the endocardium can get infected and inflamed, causing endocarditis. Blood is not a very hospitable place for microbes. There are serum proteins that can kill microbes. There are antibodies. There are marauding white blood cells. But if an organism is so adapted to be able to colonize blood, then it can grow in the blood and even flourish and cause disease and cause lots of problems. The blood should be sterile. There should not be a normal microflora that inhabits the blood. However, microbes can be introduced by something as simple as brushing your teeth. So typically, small numbers of organisms will enter the blood, but they're dealt with usually very quickly. If, however, large numbers of organisms are introduced into the blood, and if those organisms are well adapted to surviving in the blood, then you can have this situation where the blood is colonized by microorganisms, and that, of course, is called sepsis. Now, if this happens, so I have a picture here of a section of a blood vessel. This endothelial lining here, when you have areas of the blood, of the vasculature, where the blood is under high turbulence, then those endothelial cells will be subject to regular damage and repair. And it's particularly the case if we look, for example, at heart valves. So thinking about this, so if we have, say, little endothelial cells here, if you have an area that's subject to turbulence, so turbulence introduces eccentric shear forces on these cells. These cells can undergo damage. And now, so this cell here has died. And remember that endothelial cells sit, like all good epithelia, they sit on a basement membrane. Now, if this occurs, you've now exposed the blood to collagen. You expose the blood to collagen, platelets are going to alight here, and they're going to make a small little clot. So these small little clots, these can be cleared. It's not a big deal, but if this occurs on a heart valve, this is, well, or if it's really, well, it occurs on the endocardium, because the heart valves in the endocardium are really subjective to a lot of turbulence. This is called non-bacterial thrombotic endocarditis. Or an NTE. All right, so if this thing were to occur, so is that any big deal? Well, endothelium can be repaired, clots can be removed. Basically, you look at this and you say, not a big deal. But what if you have pre-existing damage to the heart valve? And then say you can introduce bacteria simply by brushing your teeth. Or you have maybe some sort of GI issue. Maybe you have ulcerative colitis. Maybe you have colon cancer. Maybe there's a lung issue. Well, the long and the short of it is that these provide opportunities for bacteria to enter the blood. And if those bacteria enter the blood, some of these bacteria have the capacity to adhere to these clots, and then they can adhere to each other because of adhesions, and then they might be able to also produce some sort of extracellular carbohydrate, form a biofilm, and now you have yourself a vegetation. And these are going to stick usually to areas of lower pressure. And if you think about it, if they stick to areas of lower pressure, it's easier for them to stick and not be displaced. So if we consider a valve, valves don't have sharp ends like that, of course. I didn't draw that very carefully. So there is a principle called the Venturi effect. And the Venturi effect merely describes how fluid pressure, so if you have, for example, a tube that narrows like this, and fluid is now going to flow through this tube like this. So the flow through this narrowed area, the speed is going to increase. But the fluid pressure decreases. So because the pressure, when you consider the valve here, where you have increased speed, so for example, let's say you have, mitral valve regurgitation. Therefore, you're going to get these little vegetations that are going to form here on the tips like that. And these are now going to produce, first of all, they're going to further damage potentially the valve, but because they're also going to induce new currents in the chambers of the heart, essentially, these are also going to produce murmurs. Now, one other thing about sepsis, when you consider a blood vessel, yeah, you could tell I never was very good at coloring. I think I just proved it right there. So then you have a proper endothelium here. So there's your intima. And that intima, again, sits on a good, solid salibamus membrane. That's your intima. There's your media. Tunica intima, tunica media, tunica adventitia. Now, if you get sepsis, and that sepsis includes gram-negative bacteria, these gram-negative bacteria have in their outer membrane lipopolysaccharide. Now, lipopolysaccharide will combine with clotting factor 7. And this will activate the alternative clot pathway. So you get this thin layer of clotted blood coating the inside of the intimal layer of your blood vessels when you have massive sepsis caused by a gram-negative organism. And when you get clots sitting against the endothelia like this, this is called disseminated intervascular coagulation. Come on, pen. Disseminated intervascular coagulation, which is mercifully abbreviated DIC. So these endothelia now start secreting tissue plasminogen activation factor, which you might know commercially as a product called TPA, which is given to dissolve clots. So what does this do? It activates the protease plasmin. So plasmin is made as a precursor called plasminogen. It's activated by TPA. Plasmin will now take these clots and degrade them, but it takes the fibrin and degrades them to so-called fibrin split products. Or FSPs. Folks, FSPs are too short to participate in clot formation, but they can interfere with clot formation. Furthermore, you've just exhausted all your clotting factors. So you're kind of, forgive the expression, doubly screwed. So this leaves the body without the ability to clot. and it leaves the body with enough activated plasmin to start chewing up other tissues. So this is going to lead to dangerously low blood pressure or sepsis. And one of the things you guys will face probably in med-surg, SOFA scores and that sort of thing, how to deal with a septic patient to keep them from experiencing end organ damage. But this is the reason why bacteremias can be so dangerous, because of DIC and low blood pressure. And not only this, but if you get organ damage, what the plasma is going to cause, your patient's going to bleed out. So hemorrhage, massive internal hemorrhage sometimes. So this is a medical emergency. And sepsis, therefore, bacteremia must be taken very seriously. Okay, a little review of pathophys there. That's okay, that'll never hurt anybody. Any questions about that before we move on? No? All perfectly clear. Okay, cool. Yeah, don't be afraid to ask questions, gang. I know on Zoom it's opportune, but don't be afraid. All right. So the symptoms of bacteremia are fever, shock, lymphangitis. Fever, shock, lymphangitis. And lymphangitis refers to inflamed lymphatics. The patient will have red streaks in the skin that you can see right here. Most bacteremias are nosocomial in origin. They can appear as soon as 24 hours after an invasive medical procedure. And treatment must address the precipitous drop in blood pressure. And so you use some pathomimetic drugs called pressors: epinephrine, norepinephrine, vasopressin, to try to raise the blood pressure, and wide spectrum antibiotics to bring the infection under control. So puerperal fever is a common cause of postpartum febrile mortality. So they'll occur either 2 of the first 10 days postpartum, excluding the first 24 hours, because some women after giving birth will spike a fever, then it goes away. This is also called childbed fever. For those of you who are students of history, Henry VIII, after he deposed and executed Anne Boleyn, he married the rather plain and some would argue homely Jane Seymour, who bore him his only son, his only surviving son, Edward. He became Edward VII, and she died soon thereafter of puerperal fever, so-called childbirth fever. And because she was the only of his wives to give him a son, she is the only one to share his grave. Sexist pig. Okay, anyway, so the infection begins in the endometrium. It then usually extends to the myometrium and then other parametrial tissues. This infection is usually polymicrobial. So you'll have aerobes and anaerobes that participate in this. So you'll usually have a fever and uterine tenderness. By fever, I mean above 100.5 degrees Fahrenheit. So we're talking fever, not fever, fever. Labs usually are not a lot of help here, but you'll have a rising neutrophil count, and you'll have lots of, because the body's making neutrophils, you'll have immature neutrophils, so-called band cells. So you're going to treat with broad-spectrum antibiotics. Group B, streptococcal disease, is usually the cause of neonatal sepsis. Neonatal sepsis. This is an infection in neonates and young infants who are less than 7 days old. Late onset neonatal sepsis can occur between 7 to 89 days. Late onset would occur after 90 days. Virtually all cases of neonatal sepsis are caused by B, streptococci, and virtually all cases are due to inoculation of the baby during childbirth. So the mother was infected with group B strep before giving birth. Risk factors include delivery at less than 37 weeks, premature rupture of membranes, rupture of membranes for greater than 8 hours before delivery. If the mom has a temperature above 38 degrees during labor, and heavy maternal colonization are all risks for neonatal sepsis. Rheumatic fever, of course, is a sequela of a Streptococcus pyogenes infection. The strep pyogenes cell wall has a antigen called protein M. Protein M. Protein M is a spiky protein that extends from the cell wall. When the immune system destroys the organism, the cells tend to last a long time. They're very hard to get rid of. And so antibodies to protein M can cross-react with heart valve tissue. And you can get inflammation of the heart valves and usually a mild endocarditis. Sometimes that endocarditis can be respectable and can damage the heart valves. Usually it's mild, but this is the reason why if someone is positive for a group A streptococcus infection of the pharynx, you treat immediately. Rheumatic heart risk goes up to 10 days of strep infection. Very good. Let's talk about endocarditis. All right, so we talked about the formation of the non-bacterial thrombotic endocarditis, the colonization of that, particularly if you have damaged heart valves. So the first group of bacteria all right, so the viridans streptococci are the most common cause of infective endocarditis. These organisms, however, their virulence is quite low. They are found in the mouth, they usually attack heart valves that have previous damage. And they result in small vegetations, and they don't destroy the heart valve. On the other hand, our old buddy here, Staphylococcus aureus, this organism is very highly virulent. It's found on the skin. It can affect both damaged and normal heart valves. It produces large vegetations, and it can destroy the heart valve. Staphylococcus aureus, when it causes endocarditis, is typically the result of intravenous drug use. So in this case, people are injecting themselves either with dirty needles or they're injecting themselves with dirty products. In this case, usually the infection is due to dental work. Dental work or poor dental hygiene. Now, what if you have a person who has prosthetic heart valves? Some bacteria love to stick to prosthetic heart valves. And the organism here is Staphylococcus epidermidis. The bacterium will tend to enter at the time of surgery. It will stick. And then they usually have these little spiky dudes on here. It will stick to these artificial valves and colonize them. The other way these can be introduced is through an intravenous catheter. Central lines can introduce them too. So that's one, that's two, that'd be three. So in other words, these infections are usually nosocomial. Two other species that can cause infective endocarditis are Enterococcus faecalis and Streptococcus bovis. Both of these are found in the gut. And so usually these cause infective endocarditis in someone with pre-existing colorectal disease. And then finally, we discussed this last time, but Coxiella burnetii, which causes Q fever. Remember, this is a zoonotic infection, which you get from cows or sheep or goats. Q fever is an infection that's a respiratory infection. It's not that severe, but sometimes months or even years after the initial infection, and usually in people who are immunocompromised, this can end up causing endocarditis because your organism hangs around and colonizes heart valves, and it's usually pre-existing heart valve defects. Now, another group of organisms that will cause infective endocarditis are gram-negative organisms that live in the mouth. And they're collectively called the PASIC group of organisms. And this stands for Haemophilus aggregati bacteria, Aggregatibacter, Cardiobacterium, Legionella, and Kingella. These can also cause infective endocarditis. But these are not as common. All right, so people with infective endocarditis almost always have a fever and a new heart murmur because the vegetations cause turbulent blood flow past the damaged heart valve. Sometimes the vegetations will detach and the little clumps of pathogens will get lodged. Those are called now septic emboli. They float through the bloodstream. They can lodge under the fingernails and cause so-called splinter hemorrhages. Splinter hemorrhages. They can also lodge in vessels in the palms or the soles of the feet and cause these flat, painless erythematous called Janeway lesions. Janeway lesions, you see one here on the hand of this individual. Now, sometimes there is an immune reaction. So you get antigen-antibody complexes that form a deposit in parts of the body, and in the fingers and toes, most commonly. These complexes lead to so-called Osler's nodes, excuse me. If these deposits form in the retinas of the eye, they're called Roth spots, Roth, R-O-T-H spots. And in the kidney, they can lead to glomerulonephritis. So an echocardiogram can be used to visualize the heart, look for the vegetations. It's important if somebody who's in a high-risk group, they have a prosthetic heart valve, or they have heart valve problems before they have dental procedures, to have prophylactic antibiotics. Here we have the Duke criteria for infective endocarditis. And you can see here you have 2 major criteria or 1 major, 3 minor. We have 5 minor criteria. And those criteria are listed here. I will let you read through those. So treatment of endocarditis always requires drug combinations because of the presence of fairly drug-resistant microorganisms. You're going to use pretty wide-spectrum antibiotics. So the come on, computer. Your mainstay treatment will be vancomycin. We've talked about the dosing of this before, but just to remind you, loading dose, 25 to 30 mg per kilogram body weight, and then 15 to 20 plus cefepime, 2 grams. Oh, and this is BID, sorry. And you're often going to have to treat for a while. You want to make sure that your blood cultures are negative. And then after your blood cultures are negative, depending on how sick your patient was, you may need to treat for 21 days, or in some cases even longer. It's going to depend. If your patient it's pretty clear that that's gram-negative, then you're going to go with your vancomycin as before, but then you're going to add things to try and hit these gram-negatives. So you could be ceftriaxone, or maybe Unisys. Remember, Unisys is ampicillin plus sulbactam. So ampicillin is the beta-lactam. Sulbactam is the inhibitor of the beta-lactamases that degrade the beta-lactam. And then what have you. If your patient has a prosthetic heart valve, once again, you'll do vancomycin. And you're going to add to this 2 more drugs, rifampin and also gentamicin. Dosing for this is by weight. Okay, so, and some people will add, in addition to these 3 drugs, we'll also add cefepime as well, but that's debated, so cefepime. Some add it, some don't, it varies. All right, so those are your treatment schemes for endocarditis. All right, it's time for our break. So, I'm on the computer. All right, so next we're going to talk about some different types of organisms that tend to infect the bloodstream. They don't start at the bloodstream, but they get to the bloodstream. So we'll go through those in order, and then we'll, yeah. All right, so 5 minutes, and then come back. Okay, it is time to resume. So these two infections here, these are worm infections of the blood. These are not infections you'll see in the West unless it's someone who has come here from another country where such infections are prevalent. So the first schistosomiasis is also known by the name bilharzia. Bilharzia. It's caused by 3 different species of flatworm. Schistosoma mansoni. Let me write these down for you. So Schistosoma mansoni, Schistosoma japonicum, and Schistosoma hematobium. The Egyptian mummies from 12,000 BC that were discovered by Napoleon had calcified eggs of schistosoma from this. So this disease has been with mankind for a very long time. So the organism lives in 3 different sets of veins depending upon the species. So hematobium lives in the veins of the urinary bladder plexus. Japonicum tends to live in the veins that drain the small intestine. And then Schistosoma mansoni lives in the portal veins that drain the liver. So these organisms have a fascinating life cycle. Let me just show you a picture from the CDC website here really fast. So the organism is shed either in urine or in feces, and when it's shed, the eggs will hatch, and they're shed into water. The eggs will hatch and they release the ciliated myristidium. The myristidium takes up residence in a snail. Different species of snails will house different species of the schistosoma. In the snail, it becomes a sporocyst. The sporocyst then is shed as a cercaria. The cercaria then will penetrate the skin when people are exposed, when the skin is exposed to contaminated water. They burrow through the skin, they get into the bloodstream, and they form this male and female pair, with the female sitting in this little gynecophoral canal of the male, and the female will then shed eggs that will get into the feces or the urine. The eggs also can cause a good deal of inflammation and organ damage in the human host. So the disease has 3 phases when you get infected. So it's the first 4 to 10 weeks after infection. That's the initial phase. So you have fever and lots of allergies. Then comes the intermediate phase, and that's the next after 10 weeks. The intermediate phase. Now you have changes in the intestine or urinary tract. And then the final phase, roughly the same in all three species. You have a skin rash, and that's due to these allergies, due to worm antigens released in the bloodstream. Abdominal pain, bronchitis. Again, this is probably due to the allergic issues. And then you have hepato and splenomegaly. And diarrhea. And the damage is usually done by the eggs. So for example, Schistosoma mannsoni releases eggs that get lodged in venules and the submucosa of the large intestine. They act as foreign bodies. They cause a foreign body type of inflammation. These abscesses will block vessels. That leads to ulceration and necrosis of the intestine in the case of Schistosoma mannsoni. As the liver starts to get damaged, you start to get ascites. Japonicum is the same, except with Japonicum, the small intestine is involved. The eggs of Japonicum can reach the brain, then paralysis in close to 10% of the cases. Hematobium is a disease that is least severe, but with this one, you get hematuria. Quite a bit of blood in the urine, and cancer of the bladder is associated with chronic infections of Schistosoma hematobium. Okay, so diagnosis, finding the eggs, in feces using a fecal smear. Problem is, this is difficult. There are ways to concentrate the eggs from feces, but this will give you false negatives. There is an intradermal test, but word to the wise, it cross-reacts with syphilis. Despite this caveat, the test works actually pretty well. Drug of choice to treat this is praziquantel. In the third world, trivalent antimonials are used. Those drugs have significant toxicity and I would not recommend their use. Best way to avoid this is stay out of the water. There are places where schistosomiasis is known to be endemic. Just stay out of the water. If the water is drawn, make sure the water is extensively filtered. Pouring it through cheesecloth sometimes can be enough. So, yeah. Okay, and that's schistosomiasis. Filariasis is caused by two different nematodes, Wuchereria bancroftii and Bia malayi. Wuchereria is Wuchereria. Bancroftii, just Bancroft with an I at the end. Brugia, Brugia. Imalai. These diseases are passed by the bite of a mosquito. And there's up to 77 different species of mosquito that can transmit these worms. So the worms live in the major lymphatic ducts. They tend to clog the lymphatic ducts and they cause edema. So you get lymphoid varices, lymph in the scrum, like you see here, hydrocele, elephantiasis. Diagnosis of filariasis is very easy. You can do, the worms can be recovered in peripheral blood smears. There's also a intradermal skin test that uses powdered dog heartworm. This test is easy to do, easy to interpret, very effective, and cheap. Very cheap. Drug of choice is diethyl carbamazine, DEC, diethyl carbamazine. It's very effective. It's been used for more than 50 years. Unfortunately, you can't get it in the US anymore. If you need it, you have to contact the CDC. And you have to show them evidence of a confirmed case. Then they'll get it for you, and you can treat your patient. It's usually a 12-day regimen, and it's usually well tolerated. The biggest side effects are the result of death of the worms causing allergic reactions. Alternative drugs are a combination of albendazole with ivermectin, but you have to treat for a year. Year versus 12 days, yeah. All right, let's talk about anthrax. So anthrax is caused by Bacillus anthracis. This is a classic zoonotic infection. Humans usually encounter it fortuitously, but very often with deadly results. It is an aerobic spore former. The spores can exist in soil for centuries. The organism is inhaled. Used to be called wool sorters disease because people who would sort the wool from sheep were at high risk for getting anthrax. There's 3 different types of anthrax. There's cutaneous anthrax, respiratory, which is definitely the most deadly, and intestinal anthrax that results from eating meat contaminated with Bacillus anthracis. So this organism produces a antiphagocytic capsule. This capsule is a polymer made solely of D-glutamate. Glutamate is an amino acid, but the glutamate in our cells is all L-glutamate. So the immune system looks at this and goes, what? So this is antiphagocytic. It then makes a very powerful toxin, exotoxin. And the exotoxin consists of a protective antigen, a lethal factor, and an edema factor. The protective antigen binds to cells. The lethal factor hitches a ride. Once this is taken into the cell, the lysosome lowers its pH. The protective factor then makes a pore under this low pH, and it propels the lethal factor into the cell. The lethal factor is an enzyme, and it degrades the mitogen activated protein kinase, or MAP kinase. Degradation of MAP kinase causes cell death. This toxin does an enormous amount of damage in the cell. So cutaneous anthrax starts a small papule that develops in a few days into a vesicle filled with a dark black bluish fluid. When the vesicle ruptures, you get this black thing that you see here. That's called an eschar. Eschar. E-S-C-H-A-R. With a prominent ring of inflammation around the eschar, just like you see here. This is sometimes called a malignant pustule. It'll heal, but it usually leaves a scar. Cutaneous anthrax is fatal 20% of the time. Inhalation anthrax is due to inhalation of the spores. It starts with a typical respiratory infection, fever, malaise, myalgia, dry cough. Then within several days, the disease becomes very severe. Respiratory distress and cyanosis. If you don't treat within this time, your patient's usually dead within 24 hours. Inhalation anthrax is fatal 80% of the time. Gastrointestinal anthrax begins with vomiting, diarrhea, nausea. There's usually hematemesis, or blood in the vomit. You can also have blood in the stools. There's usually profound prostration due to blood and fluid loss. Your patient may go into shock, death result. And the organism can invade the bloodstream and cause meningitis. Mortality of gastric anthrax depends on the dose, so it varies from 20 to 75%. Anthrax produces permanent immunity. Second attacks are extremely rare. You can isolate the organism from sputum. There is a very good enzyme-linked immunosorbent assay that's available. There are also serology tests for the toxins. PCR tests are also available, and a vaccine is available, but usually only to certain personnel who deal with animals or military personnel or what have you. Treatment is doxycycline, usually 200 milligram loading dose, followed by 100 milligrams BID, usually for about 7 days. Other drugs can be used, but doxycycline is cheap enough and it works quite well. Anthrax. You might see anthrax if you work in a farming community where lots of people associated with herbivorous animals. Plague. No other disease has received more negative press than plague. But if you read history, you'll discover that plague has rightly earned its reputation. First documented plague is the plague during the reign of the Byzantine Emperor Justinian in 542 AD, I think, was the date of the plague. I need to check that. That plague started in Egypt, lasted about 60 years. Some 100 million people died from that infection. The second pandemic was the Black Plague that occurred, it began in the 14th century. It started in Asia and spread via the Silk Road to Europe. 25 million people died. Plague became endemic among urban rat populations, so this caused outbreaks in the 17th century. The disease waned in the 19th century, but there was a third pandemic in 1855, and that was precipitated by wars in the Far East. Plague cases have waned. You can see that here. Plague is caused by Yersinia pestis, which is an organism that has some relationship to the enteric bacteria. But this is a slippery little booger. This thing has more tricks up its sleeve than that kid at high school who used to cheat at poker all the time. So first of all, it makes the capsule. That capsule is called the, let me use my blackboard to explain this to you. So this is a gram-negative organism. It's not motile. So it has a capsule that's the so-called F1 antigen. This capsule is antiphagocytic to some extent. It does not ferment lactose. So in your labs, so the vector of this organism is the oriental rat flea. And this is Xenopsila cupus. So plague is always associated with rats and fleas. Other fleas can carry it, but they're not very good vectors. So essentially, the flea is going to take a blood meal and when it takes a blood meal, if it takes up the organism, so the organism makes a coagulase. So essentially, this organism now, and this coagulase is activated at the body temperature of the flea, which is cooler than the body temperature of the rat that it just came from. So the blood now inside the stomach of the flea is going to clot. And now Yersinia pestis is going to grow inside this blood clot, and the inside the flea now, because the blood is stuck, if you will, stuck in its throat, the flea starts to starve. And so the flea now will get desperate, and it'll do whatever it can for a blood meal. So it'll hop on the next warmest animal it can find. And if the rat is dying because of Yersinia pestis, it'll hop on to whatever it can hop onto, which might very well be a human. Now, if it hops onto the human and it bites the human, what's it going to do to that big wad in its stomach in order to make a blood meal. It's going to upchuck it, so it's going to bite, and it's going to spit this big clot filled with organisms into our bloodstream. This is how this flea injects the organism so efficiently into the human. This is an extremely efficient way of passing from one organism to another. So now the flea bites the human and injects Yersinia pestis filled wad into the bloodstream, and you now have an infection. All right, so now it gets inside a warm human, and it takes about, it will then, it will occupy the lymph, and it'll infect local lymph nodes. And it's about a week later, you get these big inflamed lymph nodes near the site where the flea bit. These inflamed lymph nodes are called buboes. And the buboes may be preceded by chills, fever, malaise, confusion, nausea, and pain in the neck and back. Because of the presence of buboes, that's how come this is called bubonic plague. Now, the organism can spread if a flea bites an infected human. This will go right back to the flea. But inevitably, this is going to spread to the lungs. And now the organism causes a pneumonia. And now you have pneumonic plague. And this organism is incredibly transmissible. Essentially, you can shed a few organisms while talking, and that's enough to infect someone. And in this case, they just go straight to pneumonia. And from pneumonia, they go to sepsis. And septic shock essentially is inevitable. So the three most useful signs of bubonic plague are rise in temperature, regional buboes, and conjunctivitis. Rise in temperature, regional buboes, conjunctivitis. So if you're bitten in the arm, it's going to be your axillary lymph nodes that will show the buboes. If you're bitten in the leg, it'll be the inguinal lymph nodes that show the buboes. If you're bitten on the trunk, it's usually the hilar and the mediastal lymph nodes that show the buboes, so on and so forth. In children, septicemia occurs before the appearance of buboes. And the septic embolization to the lungs causes pneumonic plague. Usually the way you diagnose this is via serology. Very, very good serology tests. For this, you can also do blood cultures. These, you gotta wait for them to grow. You don't have time, blah, blah, blah. Serology is faster. And there's also now a field PCR test that is very good. This is not an easy organism to treat. It's not terribly susceptible to a lot of your standard antibiotics. So gentamicin, this is a good good option. You have to treat this IV. The other is possible is levofloxacin. Ciprofloxacin has been used, but there's limited clinical experience with it. And you treat at a minimum for 10 to 14 days. Plague is also a zoonotic infection, and prairie dogs have been known to get plague, and therefore people on the prairie, if they deal with dead dogs or if they're bitten by fleas that infested the prairie dog, that's called sylvian plague. And so if you come across, if you're walking in the woods, you find dead squirrels, dead chipmunks, dead raccoons, leave them be. Don't mess with them because there's the risk of sylvian plague, particularly if you're in an area where plague was an issue. Oh goodness, where does the time go? Tularemia. Now from this, you can tell there aren't many cases of tularemia in Michigan. This is a zoonotic infection. If you see this disease, it's going to be usually among hunters, people who handle animals, people who keep animals. There's several different types of tularemia. This is an encapsulated organism. It has a variety of weaponry that allows it to get away from the host immune system. It can survive inside macrophages. It produces a siderophore that grabs iron. So first of all, it can be transmitted by ticks and deer ticks and rabbits. There's several ways to get the disease. So there's 6 forms. There's ulceroglandular, glandular, oculoglandular, oropharyngeal, pneumonic, and typhoidal. Ulceroglandular, glandular, oculoglandular, oropharyngeal, pneumonic, and typhoidal. The glandular and the ulceroglandular are transmitted through insect bites, ticks, deer flies, things like that. So here you get an infection of the skin and the lymph nodes, or just the lymph nodes. If it's just the lymph nodes, it's a glandular form. In the ocular glandular form, the bacteria gain access to the conjunctiva, which is usually the result of splashing the eyes with infected material or rubbing the eyes with infected hands. Oropharyngeal is by means of ingestion of contaminated food or water. It affects the mouth and the throat. The pneumonic form results from inhalation of the bacteria straight into the lungs. And the typhoidal form can result from entry organism through any portal, and it's a systemic febrile illness. Symptoms develop after an incubation period of 3 to 6 days, and you get all forms of this nonspecific fever, chills, malaise, anorexia, chest or muscle soreness. With the ulceroglandular form, you get lymphadenopathy. The lymph nodes are red, enlarged, painful to the touch. If there's a bite, there's usually a little raised bit with a crater in the center. With the oculoglandular form, you have photophobia or eye pain due to light exposure, periorbital edema, swelling around the eyes, periorbital erythema, redness around the eye, and regional adenopathy. With laryngeal form, you get lymphadenopathy, sore throat, difficulty swallowing, and with the pneumonic form, you have dry cough, dyspnea, chest pain. And the typhoidal form, you have sepsis. Diagnosis by serology, excellent serology tests. You can culture the organism from blood, from lymph nodes, or sputum. You have to grow the organism on a medium that is supplemented with thymine and cysteine. So it's called CHAB agar, glucose, cysteine, thymine, blood agar, and it forms a greenish, white, smooth, sometimes snotty colony on the medium. There are also PCR tests that can identify the organism quite quickly. Treatment is with gentamicin. Alternatives include doxycycline or fluoroquinolones. All right, that's it. We'll try to finish this in the podcast later, maybe today or hopefully tomorrow. I will see you guys on Monday for our last lecture. We will start chapter 25 at that time. Sorry for going over time. And if you have any questions, I will hang and try to answer them. What is the exam going to look like? The exam is going to be multiple choice. It'll be online. And it'll be on Blackboard. So you'll get on Blackboard. I'll watch you take it. So that's what it'll be like.